Professor Mayank is Professor of Interventional Neuroradiology at the Foothills Medical Center in University of Calgary. And he is a key opinion leader in imaging and endovascular treatment of acute ischemic stroke. He was also PI of the allhands collaboration and ESCAPE trials. So today he will talk on challenging the ischemic core concept in acute ischemic stroke. Mayank.
Thanks, Charles, and thank you, everyone. Glad to join you virtually. Would have been much nicer to join in person, but that's the world we live in right now. So I'm going to be talking about challenging the core concept, and as the word suggests, I'm going to be challenging you to think about differently, many different concepts that I'm going to talk about. And I'm not sure how this meeting will play out, but overall, big picture, I don't mind interruptions at all. When you are giving a talk through Zoom and you have your PowerPoint open, there's this function in Zoom which is raise your hand, but that doesn't work because I will not know that you've raised your hand, sort of thing. So you'll have to almost interrupt and say that you have a question or something you don't agree with, kind of thing. So but I don't mind that at all. So please go ahead and interrupt if you wish to. So in terms of overall big picture decision making in acute stroke, we have to look at the question two ways. One is, if I treat this patient with therapy X, will the patient do better than if I did not treat the patient with therapy X? And then the second question is therapy X worth it? Will that patient do well enough? And the two questions, in fact, are in some ways related, but some ways unrelated and actually quite complicated. So there are multiple components to this question. Firstly, obviously, is how do we measure outcome? And the traditional approach is modified Rankin score. And is the MRS score 0 to 2, which is traditionally thought to be sort of good outcome, is that good enough? Or is MRS 3 good enough as well? Or is it individualized? Or is it dependent on other things? For example, let's say the patient has rheumatoid arthritis and is an MRS 3 before they had the stroke. Does that mean that they are incapable of having a good outcome? Therefore, you should not treat a person who has severe rheumatoid arthritis. And then obviously there is the individualized approach in terms of what does the person feel is a good outcome, and that is dependent on a whole bunch of other factors in terms of their value, of their quality of life, what they would like to do and stuff. And the other part that studies have shown is it's not just in an acute situation, it's also in a subacute and a chronic situation. In an acute situation, the person may feel like this deficit is really bad, but 1 year later, they may have a different perspective to it. The other problem that is there is that, that if suppose I say that for the sake of argument, for endovascular treatment, so let's say it's an 89-year-old with an aspects of 6 and who comes in 6 hours from onset. And we say if we don't M1 occlusion, and we say if we don't open the vessel, there's a 0% chance of good outcome. Then I say, well, if I open the vessel, there's a 10% chance of good outcome. So, the odds ratio will be infinity or whatever it is. And the number needed to treat would be 10, which sounds pretty good and reasonable. But is 10% good enough? Should we be treating because there is a 10% over 0%? And if you say yes, what about 9%? What about 8? What about 7? What about 5? When will you say no to it, right? And if you say no to 10, will you say yes to 11? Will you say yes to 12? So that is a problem. That is one problem that is there. The second problem, which we don't talk about enough, is this idea of confidence interval or precision. So let's say I say the likelihood of a good outcome is 30% plus minus 60%. That is completely useless information because it has absolutely no precision around it. And it becomes meaningless. So that is the other part one has to think about it is how do we calculate the precision of our outcome prediction? So here's something that we wrote about it in terms of sort of how to think about when we think about modeling, when we think about the future, when we think about outcomes. So one of the things is when you build a model, you have to think about generalizability. That is the patient well represented in the source data. So as an example, if suppose we are building a model out of the Hermes collaboration, and in the Hermes collaboration, majority of the trials did not take patients who were below aspects 6. There were some trials, obviously, like Mr. Clean. Then is that model generalizable to a patient with an aspects of 4? Right? The second part is, are we trying to answer the question, which was question number 1, treated versus untreated, or are we trying to answer the question, what would the person do if the person was treated? And in terms of treated versus untreated, you have to have untreated patients in your model. And then in terms of was the model trained in a comparable setting? So if you build a model out of Hermes and you try to test it out in China or in India, it may not work. The other part that is there is, which is relevant to our field, is if you build a model out of Hermes, then pretty much most of the trials were done between 2013, 2015, and in 2020. Is that model really valid? Have things moved on post in terms of imaging, in terms of speed of workflow, in terms of quality of reperfusion? The other part that is there is what sort of the purpose of the model. So if the purpose of the model is I'm planning my stroke ward and I want to plan out how many beds do I need and stuff, that is one kind of purpose. But the other kind of purpose is I'm using the model for decision making and prognosticating for the family's purposes. And we should think about sort of from a model perspective. And way back, Charles, you, me, and Dietrich, we went and visited this museum. I don't remember the name of the museum in Netherlands. And we were having this discussion in the cafeteria related to this idea of that once you have a model, should you give the prediction based on best case scenario? For example, I will get Tiki 3 flow in 90 minutes, or should you give us the model outcome based on an average scenario? The other part that is there is the outcome clinically relevant? Does it predict the patient's priorities? For example, let's say we say the model will tell you if it's MRS 5, 6 or not, but the patient says MRS 4 is not good enough. Is the outcome reproducible? At what stage does precision become low enough to make the model redundant? And then obviously the usual problem of dichotomization versus ordinal outcome. Then there is the issue which is there of, are the factors that we are putting into the model modifiable, not modifiable? Are there certain factors which are even knowable? So as an example, family support system is a key factor in the final outcome, but do we know about the family support system acutely when we are taking a decision? So we've been thinking about this sort of for a long time, and just as an example, in fact, Manon Kapilov prepared this slide for me, and one of the things I've been thinking about for a long time is this idea of baseline variables will only take you so far, and this is AUC 0.78, 0.77, etc., etc. And I don't really know lasso and elastic net and all these things very well. Manon made this slide as I told you, so she was trying to teach me about it, but the point that is there is that there are these, you probably heard me saying this in talks before, that at the time of decision making, there are only so much information that you know, and many of the things happen afterwards. So there are clinical variables like age, baseline NHS, time from stroke onset, pre-morbid stroke functioning are there at the time of decision making. And it's also possible that we will come to the issue of core, but many of these factors may actually be more impactful than what the imaging is. And then there is the other issue that is there is that the factors that come in after the point of decision making. And there are many people who have written about it. Obviously, you guys have been leading the charge on this. So this is Esme. This is Manon Kapilov is the second author. I'm not sure I know Lucas. And this is again the same group. So you guys have been sort of leading the charge on this idea. But at the same time, you can look at this whole problem from another perspective as well. Sorry, I'm missing a slide here. Let's see what happened. Oh, I'm not sure where the slide went. Anyway, we looked at it in Escape Anyone, and one of the things that we found was just trying to 1 second. Sorry about that. I'm just sort of making sure that okay. Well, anyway, I'll continue. I'll talk about it. So essentially, what we looked at was the relative importance of pre-factors till the point of decision making, and the post factors. And the post factors meaning speed and quality of reperfusion, and other factors such as severe adverse events, HI1, HI2, PH1, PH2, symptomatic intracranial hemorrhage, UTI, pneumonia, so on and so forth. And we're still trying to work through the details of the analysis, but the bottom line is that the post factors are just as important as the pre-factors. And if you just use the pre-factors, your AUC comes to around sort of 0.75. If you just use the post factors, the AUC comes around 0.75. Which is an interesting thing in terms of that recognition of the fact that at the point of decision making, you only have half the information. So that takes us to the same problem of that you have only half the information. So what should you do with the other half? Should you assume that the other half will pay out perfectly, or should you make it based on averages? But the other factor that is important to realize is of all the pre-factors, there's the pre-factors which are NIH, age, so on and so forth. Imaging is a tiny factor out of the pre-factors. So when you look at the overall patient's perspective of outcome, there's multiple factors, pre-factors, post-factors, and within the pre-factors, imaging is just one factor. Now, what about from a trial design perspective? So bottom line is there's lumpers versus splitters. And at the time, at least when we were designing ESCAPE, I know you guys were thinking about it differently from a Mr. Clean perspective. We thought that IMS3 has failed. So we thought of sort of a beachhead kind of trial in the post IMS3 world. And beachhead is not sort of a common term in probably Netherlands. So just to explain what beachhead is, it comes from D-Day, June 6th, 1944, when they were landing onto the 5 beaches in France. And the idea was to get a beachhead in terms of one beach out of the 5 which would get captured, and that becomes the entry point, and you go expand from there. So beachhead is you try capture a tiny amount and then grow from there. And that is the sort of the splitter approach, where you take a question and say, how do I maximize the likelihood of a positive trial, and then grow from there, as opposed to the lumper approaches that you just take all patients who fulfill that criteria and you test A versus B. And if the trial is positive, then it completely changes every aspect of it. If the trial is not positive, then you have to sort of go back to the drawing board and sort of figure out where it is. But in terms of lumpers versus splitters, it's one is at a philosophical level, the other is a scientific level. But the third thing that is there is pure and simple practical level. That sometimes what happens is, especially in trials that are done with industry support, there is no choice but to be a splitter, because the industry person is interested in having a positive trial, and they are interested in sort of putting in money appropriately. So there's that issue as well, which one needs to be sort of cognizant of. And then finally, when the trials are all done, those trials are read word for word, and a bunch of group of people get together who are generally sort of, I find very often don't live in the trenches and sort of are living in fancy offices with leather books inside them and stuff. And they look at every sentence of the NEJM papers, and then they say, this is the evidence, and we're going to write the guidelines based on that. And then essentially they say, well, majority of the trials was aspects more than 5, so let's put it in the guidelines. And majority of the trials were age A to B, let's put that in the guidelines. Majority of the trials were whatever, let's put that in the guidelines. And in the case of Dawn and Diffuse 3, those 2 trials use whatever perfusion imaging, so let's put it in the guidelines. And their attitude is guided by do no harm. That's what the evidence is. They think about payments and resources. They think about society versus individual. And very often there is also this issue that not every question is answerable with a trial, which is something which is very complicated. But very often when guidelines are written, that's not their business. They are not thinking in terms of that, oh yeah, if we extend it to this issue, that because this issue will never get answered with a trial. There is also this other question which often comes up, and which I strongly believe in is a poorly done trial worse than no trial? And to my mind, that you know, Phoenix will rise from the ashes kind of thing. Once you have a poorly done trial, that field almost dies. And I've seen this happen sort of many times before kind of thing. So I had a good friend who became a friend who had this idea of putting a balloon in the descending aorta to increase collateral flow. And essentially what ended up happening was in trial was poorly designed, poorly conducted, so on and so forth. The trial was negative. The company went bankrupt. The whole idea of collateral augmentation sort of ended up dying for 10 years. And now there is this thing of spinopalatine ganglion simulation, this trial that came out, in fact, Impact 24B. And I believe that has recently been approved. The device has been approved in Europe. So, you know, the idea of collateral augmentation ended up dying for 10 years or so because of that trial. You've heard me say that before, the brain is not the heart, so never have respect for an organ that can be transplanted. So this is Christian Bernard from South Africa. The way that it played out, the declaration of death in South Africa was different in those days compared to US or England or anywhere else or Netherlands. So practically it was not possible to do a heart transplant in the West. It had to be done in South Africa, but he made the heart a disposable organ. There's no possibility of a brain transplant. Hypothetically, if you did do a brain transplant, it would not be a brain transplant, it would be a body transplant. And incidentally, there is an interesting story, search it on the web. This Italian guy who is trying to do, so to speak, the first body transplant, he's being funded by a Russian billionaire. And he's developing the super glue, he's waiting for a donor. But this Russian billionaire is quadriplegic. And the idea is he'll disconnect the neck of this Russian billionaire and put it onto the new body. kind of thing. But that has been, I've been hearing this story for a long time. Search it on the web. It's an interesting kind of story. So what is unique about the brain? Well, there's this issue of regeneration that is there, that in terms of once a part of the brain dies, it has very limited capacity to regenerate. But that is true for many other parts of the body as well. I think one of the key issues is we just don't understand the brain relative to other organs. And I don't think that's going to change in the immediate future. The other part is the heart is generally a ball of muscle. They're designed to pump blood, same way as the tongue is a ball of muscle as well. So no difference, tongue, heart, except it's sort of differently controlled kind of thing. But the brain is obviously super complicated in terms of where does your personality live, where does the fact that you enjoy music live, so on and so forth kind of thing. And then there's this issue of plasticity, which is again very poorly understood, but that forms the substrate of recovery. And I'm sure I can keep building on this list and write 20 other things as to why the brain is unique. But obviously you guys understand that it is unique. We really don't understand brain eloquence. So this is my little guy who in fact was hanging out with Manon this weekend. He's now 20 years old or 19 years old kind of thing. This is when he was 6 months. And my brain tells me that he's kind of cute, but where in my brain is that building up kind of thing? I have no idea, and I don't think anyone knows. And that's an important aspect of the human existence, which we don't know where it lives. So just to give you an example of eloquence from a practical stroke perspective, this young person, 60-year-old, NIH 18-ish, 50 minutes from onset. This person came in, and practically speaking, when a person comes like this, I don't really care what the imaging shows. I'm going to go open the vessel at this situation. Young person, 50 minutes from onset. There's some changes on aspects on the non-contrast CT. One thing that we guys do all the time is we make MIP, maximum intensity projection, from the CT scan images. So normally CT scan images are reconstructed at 5 millimeter, and most scanners, the acquisition is at 0.625 millimeter. So you summate 8 images to make them 5 millimeter. But you can summate the 8 images using MIP, which traditionally you guys have heard more in the world of MR rather than in CT. But that exaggerates the gray-white differentiation and sort of makes it easier to identify aspects. And in multi-phase CTA, this person has relatively poor collaterals. But like I said, I don't really care what the imaging shows. The carotid is occluded, probably due to a dissection. I go in there, get past it, go into the MCA, open the vessel, and we are still at 95 minutes from onset. And this person, next day, is basically completely normal, an NIH of 3, but look at the degree of changes on diffusion imaging. And in fact, if someone looked at the diffusion imaging, they would say that the person would have significant deficit. So there is a disconnect between imaging and outcome. And this leads you to start thinking about this is not even at baseline, this is at 24 hours. So it leads you to start thinking about, are we looking at imaging the right way? And is there an issue in what we call dead brain on imaging? Is it truly dead or not? Now, obviously, there is this definition on guidelines, which was based on the 5 trials and so on and so forth in the early time window, where small cores, and at the late time window, there's a complicated framework based on CT perfusion criteria. And the other part that is there is this idea of ischemic core is used to withhold endovascular treatment. And then we'll sort of shift to that topic now. So I sort of built it up in a way that firstly, the core is a small part of outcome. But now I'm going to go on to the part about that can we be 100% certain that what we call core is irreversibly injured tissue? And what are the problems in terms of identification of core? So we wrote this relatively recently, came out in stroke. There's a couple of people who worked, Diedrich Dippel, obviously, whom you know, Art van der Loot was there and stuff. And I put together this worldwide group to work on this. And a lot of the work was done with me by Johanna and by Michael Hill. And then obviously there was a whole bunch of other people who were involved in it, and we made a worldwide group to look at it. So essentially, the transition of ischemic core to infarction is unpredictable. In fact, I'm not even sure what's the point of using the word ischemic core, and I'll come to that. Obviously, it is ischemic. We're dealing with a stroke patient. So what's the point of using the word ischemic? But the other part that is there's the influence of tissue type, duration of ischemia, cerebral blood flow, oxygen saturation, pre-morbid conditions, patient age, cell type, hypertension, diabetes, so on and so forth kind of thing. And the other part that is there is when we demarcate a certain area on a scan, whether it's MR or CT perfusion, as infarcted to uninfarcted tissue, we have a tendency to draw a line. However, it is highly unlikely that it's a sharp line. It's probably gradual and complex. Then even the area that we've marked as, so to speak, dead tissue, there's probably selective neuronal loss, selective tissue loss, selective white matter loss versus pan necrosis. And current technology does not allow us to define it. So in this one, we can say, well, this is the boundary from here to here to here. But here, how would we define the boundary? And let us say we take this tissue here. And normally, if I was to draw a curve and I was sitting as a core lab, I would draw a line from here to here to here, and then from there to there to there. And is all this tissue dead, or is there selective tissue loss? And just to remind you, these scans are at 24 hours where it's much easier. At the baseline scan, this is way tougher. So even in terms of aspects, you can look at it the same way, where you can say this is sort of darkish. Is this area completely dead? Is this area partially dead? Is this area affected or not affected? Is this area, would you draw it this way and stuff? Would you draw? And then we sort of even thought about it in terms of that should you give it sort of 1 point versus 0.5 points. So at the ESCAPE and M1 database, what we looked at is that this is the entire lentiform is gone. So we take away 1 point, but here only a part of it is gone. So, we called it a nuanced score, reduce it by 0.5. And what is interesting is that for the same aspect score, if you have the nuanced aspect score, the MRS is better in terms of nuance if the nuance aspect score elevates the aspects reading. So it's not rocket science, it's sort of somewhat expected. But the point I'm making is that just by these minor modification in the way that you think about aspects in terms of pan necrosis or degree of hyperdensity or so on and so forth, we defined it as degree of hyperdensity or degree of involvement in terms of, and we were able to show a correlation between how we define it versus not define it. And this is not in some ways rocket science kind of thing. And in fact, today on Twitter, Jens Wheeler tweeted something from his group related to that they're using net water uptake to sort of get the same idea of degree of hyperdensity, and they're finding it correlates quite well with flare diffusion mismatch for TPA eligibility. But irrespective, the point here is not to go into the details of this nuance aspects. Aspects is tough enough anyway, and encourage people to start using the nuanced aspects. The idea is to sort of recognize the limitation of what we are doing. So core has been operational defined on CTP thresholds, but there's no commonly accepted conceptual definition. For example, is ischemic core tissue that is already dead at the time of imaging? Is the tissue still alive but will invariably die? Is the tissue still alive but at high risk of dying? We haven't even reached to a conclusion on that. And then the second part that we haven't sort of defined is that, rapid map tells you 35.7 cc of core. So is that 35.7 cc, should you have a definition based on white matter? Should you have it based on gray matter? If you have white matter for the microangiopathic disease, should your definition be different? But the bottom line is a single universal core threshold, like a CPP less than 30% compared to contralateral side, to me seems absurd and will end up with wrong numbers. There's another problem that is there. When we started working on this several years ago, life was in the world of black and white movies, slow motion kind of thing. And, you do the imaging, then you think about it, then you go to angio, then you puncture, then you do an angiogram, then you sort of think about, okay, how do I open the vessel? You go futz around, put in some local TPA or TNK, or in those days, what was it called? Urokinase. And then you sort of open the vessel 2 hours later. And then you say, what was the final infarct volume? And whatever the final infarct volume was the way that you decided what the core is. And as we've got better and better and better at opening vessels, we do need to think about how the core is defined. So for example, this is from that article. So this person, in terms of the red-green maps, this red should be all core. And this was what it was on aspects. And if I was to demarcate, I would demarcate it here. And I opened this vessel within the next sort of 40 minutes or so. And the final infarct looks like this, which is dramatically different from what you thought it would. But the other part, which is more important, is this person's NIH at 24 hours was NIH of 5, starting from 18. So essentially, there's this little bit of cortical involvement. All this thing that was called red ultimately ended up not dying. And the reason for not dying is probably related to the fact that we were pretty efficient at opening the vessel. So there's also this issue in terms of that there is a very poor correlation between infarct volume at 24 hours and outcome. And this, in fact, was led by Mirel Bors and Charles, and through the Hermes collaboration. So this was Mirel published it. I'm not sure if she's in the audience or not, in JNIS in 2017. So all these people with big infarcts did well. All these people with small infarcts did poorly. And just to remind you, she painfully sat and measured these at 24 hours, not at baseline, where it's going to be even more imprecise compared to what this is at 24 hours kind of thing. And this was a paper that she wrote in JAMA Neurology. And this, in fact, was one of the most intriguing and wonderful papers, in my opinion. And somehow it didn't get as much marketed or advertised or read as I was expecting it to be. And to summarize the paper, and I'm sure you guys are already familiar with it because this was written by one of your crew. So imagine you have a person with a 50 cc infarct at 24 hours. The control arm patients do much worse than the treatment arm patients. And the first time when I saw the results, I remember I started an email chain, Charles and Diedrich and everyone was on it in terms of possible etiologies for it. And I think we did come to the conclusion that one of the likely reasons for it is selective tissue loss. That here there is much more of a pan necrosis. Here there is selective tissue loss that forms the substrate for regeneration, etc. The other possibility that is there obviously is that many of them were measured on CT, and it's possible that our ability to measure white matter infarct on CT happens when it's sort of dark enough, and here many of those white matter was sort of partially alive kind of thing. So we looked at it in Escape NA1. This is under review right now. And what we found was that in general, white matter infarct volume is way more critical than gray matter infarct volume. That if you have a 10 cc white matter infarct versus you have a 10 cc gray matter infarct, the white matter infarct person will in general do worse. And there are many different ways to think about it. One is you can say, well, it's expected because the amount of gray matter is more sort of thing. The other way to think about it is that think of it in terms of cell phones versus cell phone towers. So your gray matter is your cell phones. And if your individual cell phone breaks down, you can just borrow it from your friend or something. But if the cell phone tower is blown up, it doesn't matter who you borrow the cell phone from, you won't be able to connect kind of thing. So that's sort of another way to think about it. Traditionally, because of mass media and novels and stuff, I'm not sure if you guys grew up reading Agatha Christie, Hercule Poirot books, where it was always related to gray matter and neurons and in terms of how good Hercule Poirot's gray matter was. But actually, most of the evidence that we've seen seems to suggest that white matter infarcts end up doing worse. Now, this obviously is complicated because in multiple sclerosis, there are way more white matter lesions than gray matter lesions, and many of the multiple sclerosis patients continue to function at a reasonable level in spite of having a massive lesion load. So, it's complicated and beyond, I think, not only just my understanding, but overall sort of understanding. So here's another patient. And here, if I was to ask as a core lab to mark out the infarct, I would mark it from here to here to here. Young person, NIH 18 kind of thing. And then this is the occlusion. And like I said, 39-year-old, you're going to open the vessel. And this is the occlusion when we went in, right? And the reason I was showing you non-subtracted is because the patient was moving around, sort of thing. So one of the discussions that we had at the time between the team was that the proximal vessels are open. This vessel is supplying this area. And this area is already dead. So why bother opening it? And this is sort of the crux of very often decision-making related to imaging that happens is that area is already dead. So why bother opening it? But anyway, I went ahead and opened it, went in there, sort of the badass technique, got the vessel open. The vessel is open here and Tiki 3 flow. And this is the follow-up infarct. But the patient dropped from NIH of 18 to NIH of 8 by 24 hours. And overall started walking by day 3, day 4 kind of thing and stuff. And had a decent recovery, like MRS2, 2.5, 3 kind of thing. But compared to sort of not opening the vessel, obviously, I don't know the answer to that question. But the point I'm making is that what I would have thought to be dead brain, I was completely incorrect. And because I rapidly opened the vessel and got Tiki 3 flow, only the cortex had this bright signal. And I'm not even sure this cortex is dead because the patient was walking. So how can you be walking if all this tissue was dead kind of thing? So this tissue was probably not dead. So this idea of sort of sparing of white matter. And then we looked at it in terms of the relative importance of sort of gray matter versus white matter, corticospinal tract involvement, if it's a territorial pattern versus a patchy infarct kind of thing, and total infarct volume, obviously. Now, there's another thing that is there, which I want to point out, is that the corticospinal tract involvement has a correlation in terms of outcome. But that could also be related to the scale that we measure things on. For example, if you may give a lot of importance to patient getting up and going to pee, and they're not being able to get up, then it ends up becoming sort of an MRS3. So that's related to how we measure the score. But if you look at it differently, one could think about it in terms of what is it that is uniquely human about us, and what is it that is unlikely to be replaced by technology. So at the end of the day, if you look around you, if you have weak eyes, you put on glasses. If you have a cataract, you get your lens taken out. If you can't walk, you get a wheelchair or crutches. But if your frontal lobe is gone and you used to be a great composer of music, it is unlikely that technology will replace that in the near future. Yes, computers may compose music, but computers can't help you compose music if you can't because your frontal lobe is being affected kind of thing. So there's also that issue as well, that how will outcome measures change and what your outcome measures are important to you or to society as a whole. So why do we why do I think that we need to get rid of the term core? The point of core is it's associated with a sense of hopelessness and inevitability. Nothing can be done anymore. And that is why we suggested this term, SIT-UV, severe ischemic tissue of unknown viability. It creates a sense of urgency. It acknowledges the limitations of our current imaging techniques and our current knowledge. It sort of forces us to come up with another term, which is defining the idea core better. But at the same time, at the current moment, it does not create a sense of hopelessness and goes down the pathway of that get the vessel open as quickly as possible and sort of keep track of the data that we have. And obviously work further on imaging techniques, work further on sort of understanding how different techniques can play with each other and how it can influence our ability to be precise about the outcome measure. So where do we go from here from a clinical perspective? So one thing that we have to think about it is, what is our collective definition of futility? And I gave you that example at the beginning. What if the good outcome rate is 10%, 20%, 19%, 7%? At what stage will you say that it's futile to go and open the vessel? And how can we increase our precision around this outcome? And obviously, I don't know the answer to that question. How can we increase our precision? One simple short answer is we need to have better data sets, but those are not easy to create. And this idea of bigger data set is a better data set is the same line of reasoning as a badly done trial is worse than no trial kind of thing. So the data set has to be pretty good as well. The problem with most data sets right now is it doesn't incorporate the patients that we did not treat. The second problem with most data sets is that we don't have outcomes beyond 90 days. The third problem with most data sets is we don't have a person perspective of the outcome, as opposed to sort of just saying MRS2, but we're not sure what makes it an MRS2. Is it because they can't get up and pee? Or is it because they don't have sufficient family support? Or is it because they have problems of cognitive functioning? So just to tell you a side story, there was this Indian guy whom I treated recently, and follow up 90 days, so on and so forth, kind of thing. So the usual question the nurse asks is, can you cook your own meal? He said, no. So this is, what's the problem? He says, well, I've never cooked a meal in 75 years. I'm not going to start now, kind of thing, right? So there's also this issue of how the cultural aspects of what is an expectation of normal kind of. The other part that is there is, what if low aspects trials are positive? And obviously you guys know tension in extremis, those trials are running kind of thing, and they're running into this problem of that. I know in tension, the median age is 82 years or something like that. I don't know in extremis, which means the young patients, either they don't have low aspects or are getting treated outside of the trial. But anyway, irrespective of that problem of enrollment, what if the low aspects trials are positive? So then should we go down the pathway? We see an M1 occlusion and go open it, and then will we create a whole bunch of MRS4s and 5s who will be miserable? And what if the low aspects trials are negative? So I'm inclined to treat a young person with aspects 4, 5, and if they're healthy and stuff like that, will I be forced not to treat them? And this is that issue of, again, lumpers versus splitters kind of thing. And similarly, in the late time window, what if Mr. Clean late is negative? Right now, we don't do CT perfusion. I don't care about it. I don't care about the Dawn diffuse 3 criteria. And if a person, and very often, as you know, when a late time window person comes in, there's two aspects to it. One is truly late. One is last seen normal kind of situation, but they had the stroke relatively recently. But they all get lumped together. And right now in our hospital, we follow the same old thing in terms of sort of, is the patient worth fighting for? And is the brain generally not totally dead? Go open the vessel kind of thing and stuff. But if Mr. Clean late is negative, then does it become further set in stone that you got to follow the Dawn diffuse 3 criteria, otherwise don't treat them? And where does the issue of sort of the precision of that CT perfusion come in, and how do we sort of deal with it? And then there's obviously the idea of societal and economic aspects of our decisions, which is related to that. If suppose we feel like we are able to convert a person with MRS6 into an MRS5 or 4, we are preventing a person from dying, and in the overall big picture, Hippocratic oath and stuff like that. So if we are preventing people from death, and death is a very solid, hard outcome that was used in the hemicraniectomy trials and so on and so forth, then maybe many people could think we are doing a good thing. But what are the societal and economic aspects of our decisions? And obviously, there is another thing which is super important, is caregiver burden, which we sometimes don't think enough about. So these are the problems that we'll have to deal with from a clinical perspective. But the crux of it still comes down to is that to be able to solve these problems adequately, we do need to have a better description of in part core or imaging. And we do need to think about how that fits into our model. And we do need to acknowledge our inability to define the core. And we do need to acknowledge our inability to be precise in terms of our outcome prediction. So where do we go from here from a research perspective? And I know many of you are doing your PhDs and stuff like that. And obviously, as you know, I've been super impressed with all the PhD candidates that I've met in my various visits to Netherlands. And I always enjoy sort of this idea of spending time and teaching and interacting with you guys and arguing and stuff like that. So part of it is to sort of get you guys neurons thinking and buzzing around. So one thing that is there is we coined this term sit-UV in this paper. But at the same time, I don't want this term to stick. I want this term to fail. I want this term to fail, that I want it to be transient and ephemeral, and people to come up with better technology, better counter arguments to the idea of defining core. And then there is the issue of imaging. So in terms of whether you're directly imaging the tissue, as in CT scan, you're directly imaging the tissue, number of photons that go through versus don't go through, that creates an image. And essentially, if there's more water in there, then more of the photons go through kind of thing, as opposed to indirect in CT perfusion, which is a measure of blood flow. And is that, which is the better way? The issue of gray matter versus white matter, as I described in some of the examples. And then there's the issue of that these imaging findings, should they be put in the context of time from onset, age, white matter disease, diabetes, hypertension, et cetera, or can they be put in an absolute sense in terms of sort of, and then obviously then the other part that is there, which I've deliberately sort of stayed away from, is should they be put in the context of eloquence of the brain that is getting affected. But I'm really, really hesitant in saying that, because in my opinion, our understanding of eloquence is so poor that we have a tendency to overplay the whole motor cortex, the whole Broca's area kind of thing, as opposed to keeping it more general and acknowledging our limitations. So I'm going to stop here and thank you once again, Charles, for inviting me to this. And hopefully it's been a little bit of forcing people to think about it. And I would love to answer any questions and discussion.
Thank you, Mayank. It's a great talk, very impressive. So there is a participant button in the lower, you see it here. And then somebody can raise his hand or her hand to ask a question. You see the participant button? So are there any questions from the participants? I see a hand by Henk.
Yeah, thanks, Mayank. Great talk again. So you addressed the difficulty of inclusion criteria in trials and treatment selection based on those inclusion criteria. I think that's a main problem, and I think I see it often in when I'm reviewing papers as well. So what do you think? What can we do to change that attitude, that inclusion criteria of trials not the same as a treatment selection criterion?
Well, I think like it's not necessarily this thing that I would want to change it, because the point is the trials, depending on who's designing the trials are designed for, like I said, to get a beachhead to, especially those trials like ESCAPE and SWIFT Prime and Extend-I, and not so much VistaClean. And the way that it played out, those trials led to the guidelines. But at the same time, based on everything that we've done within the Hermes analysis, there is no subgroup where the treatment doesn't work. And the other part that is there is the natural history of disease is pretty shitty. So might as well go open the vessel.
Yeah, especially referring to Dawn and Diffuse 3. A lot of people say, oh, treatment is only effective in a late window when you follow these criteria. What do you think about that?
No, obviously, you know my opinion on it. I think it's completely incorrect to think that way. Firstly, the second thing is you don't need an NNT of 3.1 or whatever it was in those trials. You can be much more inclusive. The third thing is there is no alternative treatment for these patients. The fourth thing is that CT perfusion has significant limitations in identification of etc. But the other problem that is there is what happens if Mr. Clean late is not positive? Then the guidelines become even stronger. We reinforce the guidelines. So that is something that you guys will have to think about seriously. And I've had multiple discussions with Wim on this issue, that in terms of sort of what if Mr. Clean late is not positive. The other part that is there is you may have read my article on this thing of what I call the low-hanging fruit is already gone. So the fact of the matter is, if you take all patients together, low-hanging fruit, medium-hanging fruit, then your combined treatment effect is going to be, let's say, 20%. But now that the low-hanging fruit is already gone, your rest of the medium hanging fruit, you have to put in more effort to be able to show a positive trial. And what does more effort mean? More discipline and bigger sample size.
Yeah. large trials. Okay, thank you.
Yeah, I have a question on measuring the infarct volume on follow-up imaging. What do you think is the best method to, when to measure if you want to do it?
Short answer is I don't know the answer. The long answer is what I would love to do is to measure the degree of atrophy at 90 days. To my mind, that is the only fair measure of tissue loss. Everything else is useless. So what you do is you measure the baseline tissue volume, and then you measure at 90 days tissue volume.
Okay.
And by the 90 days, if there's bleeding in between, that'll get resolved, this, that, and the other, all those things will get sort of taken care of.
Okay, and thinking that it can be used when you want to compare different intervention techniques, to use this measurement as a surrogate outcome for the comparing different interventions, like aspiration only, or no?
No, I don't think so. Like in terms of, you mean the infarct volume?
Yeah.
No, I don't think so. Firstly, like in Merrell's paper, the Hester is in the audience, I think, and Hester was trying to once explain to me what mediation analysis is. I didn't understand it very well, so probably Hester can answer this question better than I can. But in Merrell's paper, 12% of the effect mediation was through the changes in infarct volume. So clearly differences in infarct volume will have a very poor reflection on the differences in outcome. So that is going to be a problem kind of thing. And the second thing which you and I have discussed about it is that as we put bigger and bigger catheters into the system, yes, we may open the vessel, but does the presence of the catheter influence the collaterals? And we've talked about this for several years now. We still haven't found a solution to that problem. But yeah, like in terms of sort of, I do think opening vessels is better than not opening vessels, and I do think if technique A is able to open the vessel fast compared to technique B, then I think that in itself should make technique A the way to go to, right? Not just low, so can the speed of achieving technique 3 rather than worrying about final infarct volume.
Okay. There's another question by Ed.
Thank you very much. Great talk, thank you. If the core is not a core, what about the penumbra? Should we also reconsider this definition? Or would you say the penumbra is still a reasonable area that might be saved if flow is restored in time?
Penumbra is, to my mind, a completely garbage term. It should not be used at all. It's even worse than core.
Okay.
First, we don't even have a definition of penumbra. So is penumbra the tissue that is going to die if we don't recanalize? Is penumbra the tissue that is not functioning but is alive? Is penumbra the tissue that has got a certain amount of blood flow, XYZ? So that's one problem with penumbra, that we don't even have consistency of definition and stuff. The second problem with the penumbra is that if we say it's going to die, is it going to die in 2 hours, in 5 hours, 12 hours, in 24 hours kind of thing? The third problem with the penumbra definition is I don't really care. If the patient has significant deficit in a small core, go open the vessel.
Okay, thanks you. You leave me with a lot of questions and uncertainties, but okay, thanks.
Okay, are there more questions?
There's one in the chat.
Okay. Yeah. A lot of problems with decision making seem to revolve around imaging as the biggest partaker in making a decision. Wouldn't it be good to look into other modalities or imaging techniques?
So you mean other modalities of imaging? Is that like one problem that is there is time is brain. So what you can't do is that you say, well, I'm going to start doing SPECT imaging or PET imaging and spend 65 minutes doing the imaging. So that is not feasible. The other part that is there is just about every emergency department around the world is set up around CT scans. Some places like France have it set around MR. So practically speaking, the way to think about it is you have to take it to the modality that is available 24/7, 365 is easily available. And you can spend, so if you take 2 million neurons per minute, that's your currency, you can spend 10 million neurons to get the imaging done. So which means 5 minutes of imaging. So if you think of it that way, then other imaging modalities are impossible to do and are likely will not be possible in the near future either. But the other part that is there is even within the world of CT and MR, you really have to make decisions in terms of how do you maximize information and minimize the amount of time spent.
Okay, Mayank, thank you again for your great talk.